Chapter 19, Endocrine Alterations. The endocrine glands form a communication network linking all body systems. Hormones from these glands control and regulate metabolic processes, everything from energy production, fluid and electrolyte balance, responses to stress, reproduction, and even growth. The system is closely linked to and integrated with the nervous system. Hormone release occurs in response to changes in the cellular environment or as part of the process of maintaining regulated levels of certain hormones or substances in the body. One or more of the following mechanisms regulate the release of these hormones, everything from chemical factors like blood glucose levels, endocrine factors like one endocrine gland controls another endocrine gland, or even neural control. The hypothalamus manufactures and secretes several releasing or inhibiting hormones that are conveyed to the pituitary. The positive feedback from there stimulates the release of a hormone when serum hormone levels are low. This negative feedback inhibits the release of hormones when serum hormone levels are high. When discussing stress and critical illness, there are certain diseases involving the hypothalamus, the pituitary gland, and the primary endocrine organs, such as pancreas, adrenal glands, or thyroid gland, that interfere with normal feedback mechanisms and the secretion of hormones. Crisis states occur when these diseases are untreated or undertreated, or when the patient is physiologically or psychologically stressed. The stress of critical illness provokes a significant response by the endocrine system. Excess glucose in the blood occurs because of the release of counter-regulatory hormones that promote hepatic glucogenesis and decrease peripheral use of glucose, with resulting relative hypoinsulinemia. Adrenal insufficiency can occur due to insult or damage to the gland itself, while dysfunction of the hypothalamus, pituitary, or both, or whenever cortisol levels are inadequate for the demand. Thyroid hormone balance is another one that can be disrupted by changes in peripheral metabolism that cause a decrease in the T3 levels. Pituitary and hypothalamus dysfunction as a result of a brain tumor, trauma, or surgery can cause significant fluid and electrolyte imbalances that further complicate critical illness. Whereas stress-induced hyperglycemia is a normal physiological response related to the fight or flight mode, glucose elevation has been associated with poor outcomes in hospitalized patients with and without a formal diagnosis of diabetes. Poor glycemic control affects multiple organs and is particularly problematic to endothelial and nervous tissues. The American Diabetes Association and the American Association of Clinical Endocrinologists issued a joint statement on inpatient glycemic control. The current guidelines recommend an initial target glucose level of no greater than 180, with targets of 140 to 180 being appropriate for the most critically ill patients once insulin therapy has been initiated. Glycemic targets at the lower end of this range may be most beneficial. Glycemic targets of 110 to 140 may be appropriate for select critically ill patients if the target can be achieved without significant hypoglycemia. Glycemic targets of 110 or less are no longer recommended for the critically ill patients. The effectiveness of inpatient treatment may be improved if it's based on pre-admission glycemia. However, current practice does not usually take this into account when determining glycemic targets. It is recommended that a hemoglobin A1C should be measured for all patients admitted to the hospital with diabetes or hyperglycemia if it's not been measured in the last 3 months. Continuous intravenous delivery of short-acting insulin, guided by an evidence-based protocol, of course, is the preferred method to achieve glycemic targets and optimize patient safety. These protocols include frequent glucose monitoring every 30 minutes to 2 hours, and insulin dosage adjustments based on patient-specific glucose targets to ensure the appropriate insulin dosage and minimize the incidence of hypoglycemia. The transition from IV to subcutaneous insulin therapy must be carefully timed to limit the risk for hyperglycemia. The transition protocols have been shown to reduce morbidity and decrease cost of care. Most patients may be transitioned from IV to subcutaneous insulin when they're eating regular meals or when their clinical condition warrants transfer to a lower intensity level of care. Subcutaneous basal insulin should be administered 2 hours before the insulin infusion is discontinued. It's recommended that the subcutaneous insulin regimen for a non-critically ill patient include basal, nutritional, and correction insulin components. Adjustment to the insulin dose regimen may be required if the patient is receiving enteral feedings, parenteral nutrition, or a high dose of glucocorticoids, or if the patient's blood glucose level falls to less than 100, of course. For our clinical judgment, think about the onset, peak, and duration frequencies of many of the common types of insulin given, such as rapid, short-acting, intermediate, long-acting, or even inhaled insulins. The pancreas has a complex role in digestion and metabolism. While the exocrine function of the pancreas facilitates conversion of food to fuel for the body's cells through the release of enzymes that aid in digestion, such as amylase. The endocrine function of the pancreas further regulates blood sugar as well. The pathophysiology would include things like diabetes mellitus, metabolic diseases of glucose imbalance, an alteration in insulin secretion, or even genetics. Type 1 diabetes is primarily caused by the destruction of pancreatic islet beta cells, which result in an absolute insulin deficiency and a tendency to develop ketoacidosis. In most cases, type 1 diabetes is an autoimmune disorder. A subset of patients, primarily of African American or Asian ancestry, may experience a genetic but non-immunological form of type 1 diabetes. Type 2, on the other hand, is the most common form of diabetes. It results from a combination of insulin resistance and insulin secreting defects, which cause a relative insulin deficiency. Type 2 is an example of a multifactorial polygenic disease. This complex disease or multifactorial condition suggests that the pathophysiology results from the interaction among genes, environment, and lifestyle, all combining to form some role in the condition. The basic underlying mechanisms for both diabetic ketoacidosis and hyperosmolar hyperglycemic states is a reduction in the net effective action of circulating insulin, coupled with an elevation of counter-regulatory hormones like cortisol, epinephrine, and glucagon. Together, this hormonal mix leads to an increased hepatic and renal glucose production, but it further prevents the utilization of this glucose in the peripheral tissues. The basic underlying action for DKA is a reduction in the net effective action of circulating insulin, coupled with an elevation of counter-regulatory hormones. This creates an absolute or relative insulin deficiency, with the net effect of deranged glucose metabolism. In an individual with previously diagnosed diabetes, there is a need to increase insulin delivery, as insulin needs increase with the stress of the illness. When serum glucose levels exceed the renal threshold, glucose is lost through the kidneys. As glycosuria and osmotic diuresis progress, these urinary losses of water, sodium, potassium, magnesium, calcium, and phosphorus occur. This cycle of osmotic diuresis further worsens dehydration. From there, hyperosmolarity further impairs insulin secretion in a state of insulin resistance. This absolute or relative insulin deficiency then precipitates diabetic ketoacidosis. By diabetic ketoacidosis, the initial presentation is often by patients with undiagnosed type 1 diabetes. The physiological events that increase glucose and insulin demands are not accompanied by an increase in insulin delivery. These can be underlying causes like infections, insufficient insulin relative to their needs, and severe stress such as trauma, surgery, MIs, or even pregnancy in type 1 diabetes. Interruption of insulin delivery or failure to meet physiological insulin demands may precipitate DKA. Eating disorders are more common in people with type 1 diabetes and often may manifest as failure to take required insulin doses. Glucocorticoid therapy promotes glucogenesis, glycolysis by the liver, and may even result in significant increases in insulin requirements. The may be also caused by a failure of the patient to effectively manage their sick days, which is another common cause of DKA. Individuals with DKA may lose 6 liters of fluid, resulting in classic signs of dehydration. Polyuria, polydipsia, and polyphagia are the classic 3 Ps of diabetes. Hyperventilation and Kussmaul respirations occur as the respiration system attempts to compensate the acidosis by blowing off the excess carbonic acid to bring that pH more effectively within range. Dehydration, electrolytes, and blood gas disturbances contribute to changes in mental state and may induce coma. Blood glucose levels over 250 are characteristic of DKA, but may be lower in pregnancy. Weight loss is a product of profound osmotic diuresis, while blood gas disturbances are a result of the metabolic acidosis that accompanies DKA. Serum electrolyte levels, particularly potassium, may be falsely elevated in relation to actual intracellular levels. Also, total body potassium deficits are common and must be considered in the overall management of DKA. The administration of insulin will further lower the patient's potassium levels. In the case of hyperosmolar hyperglycemic states, this condition commonly occurs in individuals with type 2 diabetes. HHS is usually precipitated by a physiologic stressor like infections, critical illnesses, that result in insulin resistance and increased serum glucose. It is more commonly seen in patients who have type 2 diabetes or no prior history of diabetes, though they also may be the initial presentation of type 2 in younger adults. However, most patients who develop this condition are older, with decreased compensatory mechanisms to maintain homeostasis. The pathophysiology of HHS is similar to that of DKA. However, in HHS, there are significantly lower levels of free fatty acids. This results in a lack of ketosis, but even higher levels of hyperglycemia, hyperosmolality, and severe dehydration secondary to osmotic diuresis. Most commonly, patients who develop HHS are older and have other medical problems such as renal insufficiency, heart failure, myocardial ischemia, and chronic lung disease, and unfortunately the mortality is very high. A variety of medications, particularly glucocorticoids and nutritional support therapies, may precipitate the condition. Other drugs that could affect blood glucose levels include thiazides, phentoin, beta blockers, calcium channel blockers, as well as enteral and parenteral nutrition. Other things to consider under judgment include an overweight patient that presents with increased fatigue, dry mucous membranes, tachycardia, hypotension, and laboratory analysis that suggests metabolic acidosis and a blood glucose of 700. The signs of DKA and HHS are related to the degree of dehydration present, as well as electrolyte imbalances. It could also be based on the severity of presentation, nausea and vomiting, the classic polyuria, polyphagia, and polydipsia, and of course the decreased level of consciousness. When comparing DKA versus HHS, the laboratory results are similar, but with 4 major differences. In HHS, the serum glucose concentration is generally significantly more elevated. Also, the plasma osmolality is higher than in DKA and is often associated with the degree of dehydration. Acidosis is not present or is very mild when compared to DKA, and the ketosis is usually absent or again very mild. For management, airway and breathing may be supported through the use of oral airways as well as oxygen therapy, intubation, or even ventilatory support in severe cases. Isotonic fluid replacement is first used to restore vascular volume and perfusion. The goal of fluid resuscitation is to prevent hypervolemia, especially in patients with ischemic heart disease, heart failure, acute kidney injury, or chronic kidney disease. A rapid decrease in the plasma glucose level, combined with rapid fluid administration, may lead to a movement of water into brain cells, resulting in brain edema, which could be fatal. Before starting insulin therapy, fluid replacement therapy must be underway, and the serum potassium level must be greater than 3.3. It's important that serum glucose levels not be lowered too rapidly, not more than 50 to 70 per hour, and to avoid the potential for cerebral edema, which could result in seizures or coma. When the plasma glucose approaches 200, 5% dextrose is added to fluids to prevent hypoglycemia and assist in the resolution of the ketosis. Insulin replacement and monitoring begin after the first liter of IV fluid has been administered, and the serum potassium level is greater than 3.3. Also, the patient is producing urine. The need for potassium therapy is based on serum laboratory results. And in the absence of renal disease, the insulin replacement and monitoring begin after the first liter of fluid has been administered, the serum potassium level is greater than 3.3, and 3 that the patient is producing urine. At that point, 20 to 30 MEQs of potassium may be added to each liter of fluid. Multiple studies have shown that treatment with sodium bicarbonate is often not beneficial and may pose increased risk of hypoglycemia, cerebral edema, cellular hypoxia secondary to decreased uptake of oxygen by body tissues, also a worsening hypokalemia and the development of central nervous system acidosis. Sodium bicarbonate is not routinely used to treat acidosis unless the serum pH is less than 7. Bicarbonate replacement is only used to bring the pH up to 7.1, but not to normal levels. A primary intervention to prevent DKA and HHS is diabetes self-management education. Survival education should be initiated and reinforced in the hospital, as well as continued in an outpatient setting. This would include things like monitoring the A1C, meal planning, sick day management, as well as hypoglycemia prevention. Quick quiz. A patient presents with a hypotensive tachypnea, fruity breath, a serum glucose of 480, a serum potassium of 5.9. What is the initial best intervention to anticipate? Would that be A, administering IV fluids, B, administering insulin, C, administering Kxalate, or D, administering oxygen? Because the patient is hypotensive, that answer is going to be A, administering IV fluids to avoid cardiovascular complications. This would be followed by administering IV insulin, and do not treat the potassium as it will adjust with the insulin therapy. A hypoglycemic event activates the sympathetic nervous system, causing a rise in counter-regulatory hormones, including glucagon, epinephrine, cortisol, and growth hormone. Those at highest risk for hypoglycemia are patients taking insulin, children, and pregnant women with type 1 diabetes, patients with autonomic diabetic neuropathy, and elderly patients with type 1 or type 2 diabetes. Hypoglycemia deals with an excess insulin or oral agents. It could also be a result of alcohol that potentiates hypoglycemic events, insufficient nutritional intake, excess exercise, medications, renal impairment, or diabetic neuropathy. With a rapid decrease in serum glucose levels, there is an activation of the sympathetic nervous system, mediated by epinephrine release from the adrenal medulla, and a rise in counter-regulatory hormones, again including glucagon, epinephrine, cortisol, and growth hormone. This compensatory fight-or-flight mechanism may result in symptoms such as tachycardia, palpitations, tremors, cool, clammy skin, diaphoresis, hunger, pallor, and dilated pupils. In most patients, the confirming laboratory test for hypoglycemia is a serum or capillary blood glucose level that's less than 70. Adults with a history of hypoglycemia unawareness, cognitively impaired elders, and older adults at higher risk for falls may have higher target glucose ranges. After serum and capillary glucose levels have been confirmed, carbohydrates must be replaced. The patient's neurological status and ability to swallow without aspiration determine the route to be used. In the event of hypoglycemia, rapid and short-acting insulin should be withheld temporarily. If the patient has an insulin pump, it should be suspended for moderate or severe hypoglycemia. Longer-acting basal insulin should typically not be withheld in patients on subcutaneous insulin therapy or who are experiencing hypoglycemia, as this will increase the risk for DKA in patients with type 1 and hyperglycemia in all insulin-dependent patients with diabetes. In the case of acute adrenal insufficiency, hypofunction of the adrenal gland results from either primary or secondary mechanisms that suppress secretion of cortisol, aldosterone, and androgens. Primary disorders result in deficiencies of both glucocorticoids as well as mineralocorticoids. The primary mechanisms, such as Addison's disease, are those that cause destruction of the adrenal gland itself. At least 90% of the adrenal cortex must be destroyed before clinical signs and symptoms appear. Primary disorders result in deficiencies of both glucocorticoids and mineralocorticoids. The most common cause of acute adrenal insufficiency is abrupt withdrawal from these therapies. Primary adrenal insufficiency has a variety of causes, including idiopathic autoimmune destruction of the gland, infections, and sepsis. HIV, tuberculosis, hemorrhagic destruction, and other infiltrations from neoplasms may also be a cause. Idiopathic autoimmune destruction of the adrenal gland is the most common, accounting for 50 to 70% of cases. The manifestations of adrenal insufficiency result from a lack of adrenocortical secretion, mineralocorticoids, primarily aldosterone, or both. The deficiency of glucocorticoids is especially significant because of their influence on the defense mechanisms of the body and its response to stress that makes them essential for life. A deficiency of aldosterone results in decreased retention of sodium in water, as well as a decreased circulating volume and an increased potassium and hydrogen ion reabsorption. These effects are seen in patients with underlying primary adrenal insufficiency, but not secondary adrenal insufficiency, and because aldosterone secretion is not primarily dependent. Primary mechanisms resulting in Addison's disease are those that cause destruction of the adrenal gland itself, and at least 90% of the adrenal cortex must be destroyed before clinical signs and symptoms appear. It's characterized by hypofunction, meaning inadequate cortisol and aldosterone. It could be caused by autoimmune Addison's disease, hemorrhagic destruction, infiltration, infections, sepsis, medications, TB, or even HIV. Secondary mechanisms that can produce adrenal insufficiency are those that decrease ACTH secretion, resulting in a deficiency of glucocorticoids alone, because these mineralocorticoids are not primarily dependent on ACTH secretion. Mechanisms that can produce this secondary adrenal insufficiency include abrupt withdrawal of corticosteroids, pituitary and hypothalamic disorders, as well as sepsis. The manifestations of adrenal insufficiency result from a lack of adrenal cortical secretion of glucocorticoids, primarily cortisol, as well as aldosterone, or even both. The primary deficiency of these glucocorticoids is especially significant because their influence on the defense mechanisms of the body and its response to the stress that makes them essential for life. Our laboratory findings in a patient with acute adrenal crisis include hypoglycemia, hyponatremia, hyperkalemia, eosinophilia, increased BUN levels, and metabolic acidosis. The diagnosis of adrenal crisis is made by evaluating plasma cortisol levels. These levels are normal in healthy individuals, but the pattern is lost in the critically ill, making the timing of the test unimportant. In crisis, plasma cortisol levels are less than 10. Fluid losses should be replaced with an infusion of 5% dextrose, and this should continue until signs and symptoms of hypovolemia stabilize. This not only reverses the volume deficit, but also provides glucose to minimize the hypoglycemia. Initially, glucocorticoid replacement is the most important type of hormonal replacement. Medications used to treat adrenal crises are outlined in the text, as well as nursing interventions in administering these therapies as described. In a patient with known adrenal insufficiency or receiving corticosteroid therapy, adrenal crisis is preventable. The thyroid gland and thyroid hormones play a role in regulating the functions of all body systems. The thyroid hormone T4, as well as T3, are secreted by the thyroid gland under the influence of the anterior pituitary gland by a secretion of thyroid stimulating hormone, or TSH. This is in turn influenced by thyroid releasing hormone from the hypothalamus. Thyroid hormones are highly bound to globulin, T4 binding prealbumin, as well as albumin. Only the unbound or free fraction of the circulating hormone is biologically active. Regulation of these hormones occurs via positive and negative feedback mechanisms. T4 accounts for more than 90% of the circulating thyroid hormones, but half of all thyroid activity comes from the T3. With aging, thyroid function declines. Hypothyroidism occurs in older adults, frequently with an insidious onset. The decrease in energy levels, the feeling of being cold, the dry, flaky skin, and other signs are often mistakenly assumed to be part of the aging, but may be signs of decreased thyroid function. Thyroid function should be assessed in any older adult patient through diagnostic laboratory testing. In the case of hyperthyroidism or thyrotoxicosis, this results from causes that increase thyroid hormone levels. The most frequent form is toxic diffuse goiter, also known as Graves' disease. It occurs most frequently in young, previously healthy females. A family history of hyperthyroidism is often present. Graves' disease is an autoimmune disease, and affected patients have abnormal thyroid-stimulating immunoglobulins that cause thyroid inflammation, diffuse enlargement, and hyperplasia of the gland. In the case of thyroid dysfunction in the critically ill, consider things like thyroid storm and myxedema coma, and all of the different roles that these thyroid dysfunction can have on patients who are in critical condition. Thyrotoxic crisis or thyroid storm is a crisis that's often precipitated by stress due to an underlying illness, general anesthesia, surgery, or infection. It can also be associated with stroke, DKA, and trauma. Uncontrolled hypothyroidism produces a hyperdynamic, hypermetabolic state. It results in disruption of many major body systems. Without treatment, death may occur within 48 hours. Thyroid storm has an abrupt onset, and the most prominent clinical features of thyroid storm are severe fever, marked tachycardia, heart failure, tremors, delirium, stupor, and coma. The severity of the hyperthyroid state is not necessarily indicated by serum levels of thyroid hormones, but rather by tissue and organ responsiveness to the hormones. Thyroid hormone levels are elevated. However, these levels are generally no higher than normally seen. And primary glandular diseases, the TSH will be exceptionally low due to negative feedback. Specific pharmacological management of thyroid storm is described in detail. The primary objectives in the treatment of this thyroid storm are antagonizing the peripheral effects of thyroid hormone, inhibiting thyroid hormone biosynthesis, blocking thyroid releasing hormones, providing supportive care, and identifying the precipitating underlying cause. In the case of thyroid storm, symptoms are aggressively treated. Acetaminophen is used as an antipyretic, while cooling blankets and ice packs may also be used. Cardiac complications are treated with pharmacotherapy such as beta blockers. Oxygen is administered to support the respiratory effort, and the large fluid losses are replaced while hemodynamic monitoring may further be required. Nutritional support is also provided. Quick quiz. What strategy is helpful for promoting nutrition in the patient with thyroid storm? That be A, providing high-calorie, high-protein oral diet. B, inserting a feeding tube for enteral nutrition. C, start TPN via a central catheter. Or D, provide ensure or boost supplements if the patient will not eat. That answer is going to be A, provide high-calorie, high-protein oral diet. The patient needs an easy-to-digest, high-calorie, high-protein diet to correct the excessive caloric expenditure and muscle wasting that accompany thyroid storm. On the other hand, a myxedema coma is the most extreme form of hypothyroidism and is life-threatening. Myxedema coma is the absence of an associated stress or illness, is uncommon, with infection being the most frequent stressor. The addition of stress to an already hypothyroid patient accelerates the metabolism and clearance of whatever thyroid hormone is already present in the body. This hypothyroidism disrupts the normal physiological of most body systems and occurs insidiously over months or years. The underlying causes of myxedema coma are those that produce hypothyroidism. Most cases occur either in patients with long-standing autoimmune disease of the thyroid, such as Hashimoto's, or in patients who have received surgical or radioactive iodine treatment for Graves' disease and have received inadequate hormone replacement. The patient in hypothyroid crisis may present with somnolence, delirium, seizures, or coma. Personality changes such as paranoia and delusions may also be evident. Slowed motor conduction produces decreased tendon reflexes and sluggish, awkward movements. Cardiac function is depressed, resulting in decreases from baseline in heart rate, blood pressure, contractility, stroke volume, and cardiac output. The patient may develop a pericardial effusion, making heart tones distant. Many of the manifestations are attributable to the development of edema. This interstitial edema is the result of water retention and decreased protein. Fluid collects in soft tissues such as the face and in joints and muscles. Facial edema and an enlarged tongue are also classic signs of myxedema. Respiratory system responsiveness is depressed, producing hypoventilation, respiratory muscle weakness, and CO2 retention. This may further contribute to decreased mentation. Patients with hypothyroidism are unable to maintain body heat because of the decreased metabolic rate and decreased production of thermal energy. Hypothermia is present in 80% of patients with myxedema coma, with temperatures as low as 80 degrees Fahrenheit. The low metabolic rate and resulting decreased mentation produce both physiologic and physiological changes. The patient in hypothyroid crisis may present with somnolence, delirium, seizures, coma, in addition to personality changes such as paranoia and delusions. Slowed motor conduction produces decreased tendon reflexes, awkward movements. The patients may also experience muscle aching and joint stiffness. As with other disorders that involve hypothalamic and pituitary regulation, in primary disease, the end hormones T3 and T4 are decreased while TSH increases as the pituitary gland attempts to stimulate the non-responsive gland. In primary endocrine disorders, stimulating hormones typically are released while the final glandular hormone levels are decreased. When dealing with myxedema, interventions would include treating with replacement thyroid hormone, fluid and electrolyte replacement, thyroid replacement that usually corrects the sodium as well. You also want to monitor gas exchange and respiratory status carefully, in addition to cardiovascular status, managing the hypothermia, protecting from injury and infection, and educating and including the patient as well as their family. Quick quiz. A patient who has previously undergone a transphenytoid hypophysectomy has been non-adherent with hormone replacement therapies. Which lab findings would be consistent with this patient's history? Would that be A, a decreased T3 and T4 with a decreased TSH? B, a decreased T3 and T4 with an increased TSH? C, a decreased cortisol and increased ACTH? Or D, an increased cortisol and decreased ACTH? That answer is going to be A, a decreased T3 and T4 along with a decreased TSH. The removal of the pituitary gland results in an inability of the gland to produce the thyroid stimulating hormone, which further results in the decreased T3 and T4. Let's talk about sodium disorders and critical illness. Hypernatremia is characterized by a serum sodium over 145 and most commonly occurs due to excess loss of free water, leading to increased serum osmolality and increased serum sodium. Loop diuretics, an inability of the kidneys to concentrate urine, vomiting, diarrhea, and excessive sweating may also lead to hypernatremia. Rarely, hypernatremia may occur due to hypervolemia as a result of an infusion of hypertonic saline solutions, heart failure, or oversecretion of ACTH. When assessing for hypernatremia, we'd be looking for signs of hypovolemia, oliguria, orthostatic hypotension, dry mucous membranes, tachycardia, and especially confusion and altered levels of consciousness. On the other hand, in the case of hyponatremia, we'd be looking at headache, lethargy, confusion, or even seizures. When treating these conditions, for hypernatremia, we'd be looking at fluid replacement with hypotonic fluids, avoiding too rapid a correction of the serum sodium, with a recommended correction of 0.5 MEQs per liter per hour, or 12 MEQs per liter per day. In the case of hyponatremia, we're looking at slowly increasing the serum sodium, no more than 12 MEQs in the first 24 hours, as that rapid correction can result in cerebral edema. The antidiuretic hormone ADH. The primary function is the regulation of water balance and serum osmolality. It regulates water balance. It's produced in the hypothalamus and stored in the posterior pituitary. It can be triggered by serum osmolality, blood volume, blood pressure. Two common disturbances of ADH are diabetes insipidus and syndrome of inappropriate secretion of ADH, or SIADH. A less common disorder is also cerebral salt wasting. This is a disorder of sodium and fluid balance that occurs in patients with a neurological insult. The pathophysiology is a deficiency in the synthesis or release of antidiuretic hormone. and it results in excessive water loss. The types could be everything from neurogenic, nephrogenic, or secondary, such as excessive water intake. A specific listing of causes of neurogenic diabetes insipidus is included, but what is common about all these causes? They either involve direct damage to the pituitary gland or hypothalamus, or increased intracranial pressure. The primary causes of neurogenic diabetes insipidus is the traumatic injury to the posterior pituitary or hypothalamus as a result of a head injury or surgery. Transient diabetes insipidus may occur after trauma to the pituitary, after manipulation of the pituitary stalk during surgery, or as a result of cerebral edema. Permanent diabetes insipidus occurs when more than 80 to 85% of hypothalamic nuclei, or the proximal pituitary stalk, is destroyed. During assessment, we're going to be looking at things like high urine output, thirst and polydipsia, hypotension, decreased skin turgor, dry mucous membranes, tachycardia, weight loss, and other neurological changes, including hypernatremia and hypovolemia. Here we just have a chart showing our indicators of diabetes insipidus, including sodium, osmolality, within both the blood as well as the urine. For interventions, volume already lost must be replaced. In addition, fluid is replaced every hour to keep up with current urine loss. A correction of hypernatremia and replacement of free water are achieved by using hypotonic solutions of dextrose and water. If the patient has circulatory failure, isotonic saline may be administered until hemodynamic stability and vascular volume has been restored. Nephrogenic DI is treated with sodium restriction, which decreases the glomerular filtration rate and enhances fluid reabsorption. Patients who have permanent ADH deficit require education regarding medication management and recognition of signs of inadequate or excessive therapy. Excessive therapy may produce signs of syndrome of inappropriate antidiuretic hormone, and inadequate therapy may also cause a DI condition. SIADH results from excessive production of antidiuretic hormone with a resultant retention of water and plasma hypotonicity. SIADH may be neurogenic in origin, resulting from damage to neuronal, pituitary, or hypothalamic tissue. The condition also may result from endogenous release of ADH from ectopic sources, such as tumors and pulmonary disorders. This occurs when there is a failure in the negative feedback mechanism that regulates the release and inhibition of ADH. CNS disorders such as head injury, infection, hemorrhage, surgery, and stroke stimulate the hypothalamus or pituitary, producing excess secretion of ADH. A common cause of SIADH is ectopic production of ADH by malignant disease, especially small cell carcinoma of the lung. Other types of malignancies known to produce SIADH include pancreatic and duodenal carcinomas, Hodgkin's lymphoma, sarcomas, and squamous cell carcinoma of the tongue. Neurological manifestations such as weakness, lethargy, mental confusion, difficulty concentrating, restlessness, headache, seizures, and coma may occur in response to hyponatremia or hypoosmolality. If the serum sodium level decreases to less than 120 in 48 hours or less, serious neurological symptoms and mortality rate as high as 50% can result. Fluid overload in the pulmonary system also produces increased respiratory rate, dyspnea, and adventitious lung sounds, as well as that frothy pink sputum. Here again we have the laboratory indicators of SIADH for both sodium as well as the osmolality in both serum and urine collections. The primary goal of treatment of SIADH is going to be to treat the underlying cause, eliminate excess water, and increase serum osmolality. The treatment of SIADH, both of which may induce diabetes insipidus, are used in the treatment. Fluid intake is restricted to 800 to 1,000 milliliters a day with a liberal dietary salt and protein intake. Patients with any type of serious brain insult may develop cerebral salt wasting. Brain trauma, subarachnoid hemorrhage, ischemic stroke, spontaneous intracranial hemorrhage, and meningitis are associated with the development. CSW occurs in up to 40% of traumatic brain injury cases and is associated with increased morbidity and mortality. During assessment, we're going to be looking for symptoms like tachycardia, weight loss, hypotension, dry mucous membranes, lethargy, weakness, mental status changes, seizures, and even coma. And here again, we have our common laboratory indicators. The primary goal of treatment is going to be to simultaneously restore both sodium and fluid volume. Replacing fluids without sodium may worsen the hyponatremia, resulting in life-threatening consequences. Both isotonic saline and hypertonic saline could be used. Isotonic saline is administered to replace volume at a rate to match urine output, while the hypertonic saline is given in the presence of cerebral edema, so that the sodium levels increase at a rate of no more than 12 MEQs per liter in 24 hours. Our key points from this module is that endocrine function is a complex feedback system. And when dealing with diabetes mellitus, there are many serious conditions that occur. Everything from diabetic ketoacidosis to hyperglycemic hyperosmolar states, as well as hypoglycemia and hyperglycemia that you've no doubt encountered at your clinicals. Other complex endocrine conditions, things like adrenal crisis, thyroid disorders like thyrotoxic crisis, myxedema coma, and pituitary disorders like diabetes insipidus, SIADH, as well as other electrolyte and metabolic concerns. But anyway, that's all we got for this chapter. I'll see you in the next slides.